Okay, and sorry about this. We can take one from the audience now. Does anyone have a question? Do you mind using the microphone or I can just repeat it?
Just repeat it. Yeah.
Yeah, so yes, the question is about epilepsy, whether epilepsy can be treated with DBS. The key there again is patient selection, but epilepsy was tested through a rigorous double-blind trial that the FDA said, look, there's a benefit there. So there are 3 different neuromodulation devices for epilepsy, and the world of epilepsy is completely, it's got its own nuances in terms of like less invasive, less destructive, but less efficacious versus the most invasive operations also being the most effective. And so an epileptologist is the one who kind of helps navigate what's the appropriate strategy. Yeah, again, it's with epilepsy, I mean, it can take, I would say it probably takes about a year at least for a team to kind of decide which surgical treatment to use to make sure that they've considered all options. So it's even more than what we're talking about. It takes a village to make these treatment plans.
Thank you. Will DBS or focused ultrasound alleviate any internal tremors that someone may have in their abdomen?
That's a great question. Dr. Ponce.
You want to try that one?
Yeah, the answer is no. And in fact, I can remember maybe at least a handful of patients of mine that have tremors, and their external tremors are so well controlled with DBS, and then they kind of say, can you get rid of my internal tremor as well? So internal tremor means they're vibrating inside of them. And the most common location is in their chest, or sometimes just inside their head, or sometimes, they feel it inside their arm, and yet nobody sees a tremor. And it makes me wonder whether the so-called internal vibrations are the so-called physiologic tremor that we talked about, right? We talked about all of us here in this room having physiologic tremor. We just don't see it. We don't get bothered by it just because we're so used to it. It's like that background noise that you eventually habituate to. You don't see yourself tremor, and yet some patients have a heightened perception of this physiologic or internal tremor. And this doesn't respond to anything. It doesn't respond to medications. It doesn't respond to deep brain stimulation adjustments, in my experience. So those patients of ours that are frequent flyers for DBS adjustments are going to say, well, we love to see you, but we're not going to get rid of that internal tremor ever. Although I do advise them to cut back on caffeine, make sure their thyroids are good, cut back on some stimulants, which can enhance this internal tremor.
Thank you. And how do you determine if someone who's diagnosed with multiple system atrophy would be a good candidate for DBS?
Okay, first I'm going to ask Dr. Ponce, have you done anyone with MSA, multiple system atrophy? Yes, I've had one patient that basically was with a movement disorder specialist and came back, was like, well, it turns out it's not Parkinson's after all. That's where having a village helps, is that she also had trusted the care she had even though the diagnosis changed. And we ended up actually removing the device, the battery and the wires down the neck, but she wanted to leave the wires in the brain just because she didn't want to expose herself to any risk on that front. But yeah, she had the device removed. So it doesn't work. Sometimes things that look like Parkinson's but are not Parkinson's disease, it may look okay for a couple months, but it wears off. And it becomes pretty apparent that it's not Parkinson's disease. I've had a couple of patients, at least I can think of, that we diagnosed with Parkinson's, years and years before, had deep brain stimulation with good control of their tremor, but no control of their bradykinesia, which is the slowness of their gait or rigid muscles. So, and then when the DAT scan came about, and now the skin biopsy came about, and now we're able to fine tune the diagnosis. And at some point, I kind of say, wow. You probably didn't have Parkinson's disease, but in hindsight, you probably have multiple system atrophy, which is MSA. So what is the long-term benefit for these two patients I can think of? The tremor responds and long-term, but boy, it doesn't have any benefit for the walking, the balance, the speech, the rigid muscles, the falls,
dysphagia, drops in blood pressure, and so on and so forth, which are pretty common in MSA patients. But Dr. Ponce is right. I mean, if MSA is the running diagnosis, will I push a patient for surgery for DBS? The answer is probably no, except if patient wants one symptom treated, which is tremor. So tremor in MSA will respond to DBS.
Thank you. Do we have any questions? Anyone over there?
I just had my second surgery Monday, and Dr. Conklin is a terrific surgeon, but he's not much of a therapist. And he tested me every which way. There's a mountain, and I have head shaking, and my hand sometimes inside it felt. And so I always have two tune-ups on their hip. And I am just.
Ask your freaking doctor.
I'm hoping did so well.
Thank you for sharing that.
Thank you
Yeah.
for sharing.
Yeah, thank you. Yeah, but do you mind if I just mention a few things? So there are cases where, remember I showed you slides of, is this essential tremor or is this essential tremor that has developed Parkinson's disease? And so sometimes or should I say oftentimes, you get diagnosed with what's called tremor predominant Parkinson's, or if we don't do any workup, we'll probably just say you have essential tremor. So why is it important to nail down that diagnosis and determine whether this is just pure essential tremor versus ET with PD, which can exist, right? I showed you those slides. And the reason is we now do dual targeting. So dual targeting means one target for the tremor and another target for the Parkinson's. So we don't do that for run-of-the-mill Parkinson's disease. We don't do that for the run-of-the-mill garden variety essential tremor. We do it for patients that I think have essential tremor plus Parkinson's, or even just Parkinsonism. So for instance, if the skin biopsy is positive for alpha-synuclein, and you have years and years of diagnosis of essential tremor, what target would I most likely choose? So I'll probably choose the tremor target, which is VIM, plus the Parkinson's target, which is the subthalamic nucleus. And maybe Dr. Ponce, you can explain a little bit about this dual targeting and how is it any different from the traditional, ET only or PD only DBS?
Yeah, so the way we get to the brain, so there's nodes within the brain. Those are the targets we use for DBS. Those spots that are part of the circuit that if we tap into that spot, we can kind of reset the circuit. And then there's how we get there. And we want to make sure we access those areas through safe pathways through the brain. And so right behind the forehead, there's an area of the brain that we call non-eloquent, because if there's some swelling or a little bit of blood, it's not going to it's not going to cause paralysis. It's going to be well tolerated, and you can recover. There's another spot in the brain that's kind of up and behind the ear that we often use to place shunts, for example. We can pass something through the brain to reach another location. And so these are safe entry points. And it turns out that if you say there's two parts of the brain that there's different parts of the brain that we can use to do DBS, right? And so say you draw a line between two areas of the brain and you see where that line ends up. Now, if it goes out of your mouth, we're not going to go through your mouth to do the operation, right? But if it goes through a safe spot, we're like, hey, wait a minute. If we, instead of doing the surgery from behind the forehead, we go from above and behind the ear, we can get two for the price of one. With one wire, one pass, we can actually pass the electrode to the tremor spot as well as the Parkinson's spot. And it turns out the relationship between the Parkinson's target and the essential tremor target, when you project it out, actually lands in a very safe area that we can access for surgery. And so, and what's kind of neat is, regardless of the haircut, on those patients, when you look at them from the forward, there's no evidence of this surgery because it's all in the back. But you're face down for the operation, and but that's how we kind of started doing this. Was that looking at those two areas, say, look, we project it out, that's actually a safe spot to enter. If you go right where vision is or right where motor function is, that's a no-fly zone. So there's areas in the brain that are no-fly zones, and there's other areas that we say, we can pass something through here safely.
I have a question here, which I think is something that will interest everyone. I'm in my 80s. Do I qualify for ultrasound or DBS or both, or neither?
Yeah, so obviously there's always caveats, but I think for the purpose of your question, in your 80s, I'd say you still qualify for both. That's when we factor in your physiological health, right? Your physiological age, what your medical comorbidities are, kind of where you and your family are in terms of what your goals and values and beliefs are in terms of what you want out of your next, 5, 10, 15, 20 years. But yeah, it's all done on a case-by-case basis. Dr. Evidente and I have a number of patients in their 80s for not only essential tremor, but also for Parkinson's, which Parkinson's would be considered a more frail population in their 80s than essential tremor.
There you go. Thank you. Thank you for sharing that.
Yeah.
Okay, but you have to be a good 80. So not every 80-year-old will make it. So for instance, if you have a laundry list of medicines and comorbidities, congestive heart failure, cancer in remission, liver failure, bad uncontrolled diabetes. Okay, that's not a good 80, right? So you have to be a good 80 medical-wise and a good 80, cognitive-wise. So we do we send you to a neuropsychologist who will map out your cognitive faculties. You must be good, cognitively intact to make it to DBS, at your age.
Yeah, 85 days out of surgery, out and about. Congratulations.
Yeah.
We'll take one more in person here.
My cards don't believe in open medication, basically, is doing its job. But the side effects of lack of energy, bad taste, constipation, if I had the DBS, will all those symptoms go away?
That's a great question. You see, the philosophy among movement specialists and DBS centers is different from one center to another. At least in our center and with our team, with Dr. Ponce, we aim to reduce their Parkinson's medicines all the way down to 0, if possible. And so we're able to achieve that, anywhere from, I'd say, so far the gold medal winner is about 2 weeks. 2 weeks post-op. These are mostly patients with low doses of medicines and you have side effects from medicines that they don't tolerate. So the higher the dose of medicines that you take before DBS, the longer it takes to reach that 0, or the less likely you will reach 0. But the average published data out there will quote about 50% reduction in medications. But we aim for that, more than 50%.
All right, did you have any more on there, or did you want to take any other?
No, just one more maybe from the audience.
One more. Anyone have a question? Okay.
Hi, Dr. Evidente.
Hello there.
When you talked about the DBS for one area, so for cases you want essential tremor, but then is it also work on the dystonia?
The answer is yes. Yeah. So for instance, thalamic DBS cannot benefit both essential tremor and dystonic tremor. The answer is yes. Although if you have a focal, tremor of the head that is associated with the dystonia, so-called dystonic tremor, I favor the target called GPI. But if you have both essential tremor and a dystonia, the thalamus will work pretty well as well. And this we saw in patients with, we published on this just a couple of years ago with Dr. Ponce. We have a series of patients with spasmodic dysphonia, which is a focal dystonia of the vocal cortex. They sound like this, they're like choking. This is how they sound. It's called spasmodic dysphonia, and it's dystonia of the larynx. And so, most of these patients also have, at least the one that we saw in my center, also had tremors of the hands. And so when we do the VIM, DBS, not only did we see improvement of their hand tremors, we saw improvement of the focal dystonia.
And then finally, from my understanding, the focused ultrasound only works on the extremities, so your hands, so it really work for head.
Correct, because you remember what I said about deep brain stimulation for tremor? If it is a midline tremor, meaning your head, your voice, your trunk, you need both sides done. I don't think, Dr. Ponce, you would recommend bilateral focused ultrasound thalamotomies?
No, I think it's the, and I always kind of, my crutch is always what the FDA actually says, like and they say basically appendicular tremor, upper extremity tremor, like anything beyond, like even head tremor, we usually say, look, we know kind of what to quote for hands. I think anecdotally with me and Dr. Avedente, head, yeah, we're good. You're with a good team, let's go for it. But it's not like the FDA says DBS works for head tremor. It's that from our experience, and it's been published, but we know it works. But we want to make sure, I especially, as part of my informed consent, that we separate kind of off-label versus on-label goals of treatment. And what the FDA says is we're going to treat the hands with DBS and for focused ultrasound. And because of that, where we are with our experience with focused ultrasound, I think in terms of helping you get to where you want to be, we'd be more likely to say, you should consider DBS, because this happens in all of surgery. It's like, all right, this is what Dr. Avedente feels is like, this is where you want to be, and this is where he knows he can get you. And sometimes, in the case of DBS, you can't get there without DBS. And similarly, when weighing the two options, I don't think we have enough experience to, maybe in 10 years we'll be like confidently, yeah, let's tackle this with an ablation, but right now we're not there.
Okay,
Okay, thank you both.
thank you.